Good morning, good afternoon, and good evening, everybody. Thank you so much for joining us in this session 9. Welcome everyone again. And today we will have a very interesting session with a very significant topic for the public health perspective and for the health sector. I'm Daniele Magalhães. I'm the Senior Project Director at the Global Consortium on Climate and Health Education. And together with the Global Network of Academic Public Health, we are developing this training, and together also with the support of all the regional associations of public health. So you already know that we have closed caption. If you want to have closed caption in English, you just need to click in the button on your toolbar, the CC button. And if you want to have closed caption in Spanish, the link will be available in the chat. We are in session 9. We have 3 more sessions to end this course. And today we are going to understand the challenges and opportunities for ensuring equitable access to healthcare during climate-related disruption while maintaining the quality of care for vulnerable populations. We are going to identify the risks and vulnerabilities to critical healthcare infrastructure, delivery, and supply chains. We are going to identify ways to improve the resilience of healthcare facilities, and we will learn how to use emergency planning skills to plan for and respond to climate-related extreme weather events. As you already know, this session has 90 minutes. We will have 40 minutes expert lecture, followed by 2 case studies presentation. And at the end, we will have a discussion, and I would like to invite all of you to put questions to the speakers in the Q&A, not in the chat. The video, the session video will be recorded and will be available at Canvas via Columbia Plus. And I have some important information also for you regarding to the final exam and to recordings. So your attendance, how we record your attendance. Your attendance will be recorded in a combination of two ways. One is the Zoom session. If you are here using your personal Zoom link, your attendance is automatically recorded. And also if you watch the video at Columbia Plus Canvas, your attendance is also recorded. So for the final exam will consist in 25 questions. There will be multiple choice and true or false, and the link will be sent at the very last session. So when we finish the session, you will receive the link to do the final exam. You don't need to do immediately. You have until November 30th at 11:59 Eastern time. So pay attention of the time in your region. This is Eastern time. So if you are not sure, complete everything by November 29 and you are going to be fine. If you are participating asynchronously via Columbia Plus, you have also until November 30th to watch at least 8 of the 11 sessions recording. So you can have the attendance requirement to be able to have a certificate. And if you already attended 8 live sessions at Zoom, you can also review the recordings that they are already in our YouTube channel. I can share with you later by the end of this session. And pay attention, because watching in YouTube will not record you as attendance. So you need to be in Columbia Plus Canvas to mark your attendance. And the certificate will be issued by December 19th. So please check your email after this date, and you don't need to reach out to us before this time because we will be working on this issue. And if you haven't already, please join the WhatsApp group because we are going to include a lot of information there and a lot of doubts that you may have regarding the certificate, regarding the final exam. So please join the WhatsApp group. And today we have a very international panel. We have Dr. Aditya Vyas from Australia, Dr. Haji Ghosh from India, Dr. Philip Darling from US, and I would like to introduce our first speaker, Dr. Aditya Vyas. Is a public health physician and quality and safety specialist at the Western Sydney Local Health District with extensive leadership experience in Australia and global advisory roles in WHO and the UN COP28 Health Program. He is currently co-chair of the Climate and Public Health Education Network, which is hosted by the Council of Academic Public Health Institution Australasia, CAFIA. Dr. Adi, as I said, is in Australia, and it's not feasible for him to be here live, and he sent us a video. And I will stop share so you can have the recording.
Hello, everyone. It's an absolute pleasure to be presenting at today's session on the Climate Ready Classrooms course for Public Health Faculty Development on Climate Change and Health. My name's Dr. Adi Vyas. I'm a public health physician based in Australia. And over the next 40 minutes or so, I'll talk you through some of my own experiences in working in this area, as well as about a 10-year history over which I've taught on this subject as well, both at medical school level and the Master of Public Health level in the UK and Australia. It's a pleasure to be invited to speak here with you through the global network of academic public health institutions, GNAPH, as well as GCCAG. I am presenting on health system responses to climate change, and this is session 9, which is termed Strengthening Health Services and Ensuring Health Service Delivery. I'll now share my slides with you, which give you a sense of the topics we'll be covering. It is a somewhat long session, so I'll break it up into a few different sections, and throughout I'll be embedding some kind of top tips for how you might go about teaching on this quite large and complex topic. This session is delivered in 3 parts. First, I'll be framing the health impacts of climate change. No doubt you've covered this previously, but just to bring us to the point of what this means for health services, responses, and impacts from climate change. That will be the focus of part 2. And then finally, in part 3, we'll have a bit of a rapid fire set of solutions and actions. This is an area where so much is developing contemporaneously across different countries. So whether you're an educator, whether you're a practitioner in public health, or a bit of both like me, there's a lot to cover, and there's innovation occurring throughout this process. So probably my key take home or takeaway from this session is collaborate, collaborate, collaborate. I've put my email address here, and it'll be a pleasure to speak with many of you afterwards. My apologies that I can't be presenting this session live, and hence you have me pre-recorded here. All right. Let's think about how we frame the health impacts of climate change. Typically, we might think about impacts to patients. My day job is as a doctor in a health service in Western Sydney, and the focus of my role is on quality improvement and quality and safety. Sometimes we call this clinical governance. Now, the focus there is entirely on patients, but also the systems surrounding them that enable good care delivery. This actually does extend out to populations, and that's where many of us come in from a public health perspective. But really, it's underpinning the kinds of services we deliver, whether these are curative treatment-based services or indeed public health and prevention-based services. Let's start there with the role of public health practitioners. Can you think about a time when you or your local area, your local community was faced with a public health disaster or crisis due to climate change. For me, it was no clearer than the summer 2019 or 2020 bushfires that we faced up and down the east coast of Australia. And some of the first locations that were actually identifying the impacts of these bushfires were our health services. So, for example, we had a base hospital that was a referral site for many of the rural areas, which was in the mid-north coast region. And it was actually the anaesthetists in this hospital who were monitoring the air pollution and telling us centrally at the Ministry of Health in Sydney that they had to cancel some of their services or some of their surgeries because of the indoor air pollution impacts and the inability to intubate a patient. So the impacts from these environmental incidents through to health and the ability to operate health services are very, very clear. From a teaching point of view, I find anecdotes like this are quite arresting or grabbing to students. And often it is the lived experience that makes this more palatable and just makes it a lot more easy to approach. And so from a teaching point of view, I often like to invite colleagues who have had that practitioner role, who can be a guest lecturer and actually talk about what they did during these critical events. It's also quite nice to reflect on what this means for our colleagues in other countries or nearby locations. So this is a picture from Fiji, where Cyclone Winston in 2015 ripped through the centre, as you can see on this top right here, ripped through the centre of the country, affecting both of the main islands. Now, a lot of these communities and health facilities have not been rebuilt since people have had to relocate, and there's quite a sophisticated process to do this locally. But it's just a nice reminder that, in fact, these challenges that we're facing and the health inequities secondary to climate change are being faced around the world to greater or lesser degrees. One of the learning outcomes talks about how we frame climate change in terms of the direct impacts and the indirect impacts. So I'm trying to tick that off here in this slide. This is a piece of work some colleagues and I did at the Ministry of Health in New South Wales, but this should not come as a kind of new content to you, hopefully, at this stage. What we're looking at here is essentially, I'm just going to pause to find a marker. What we're looking at here is these health impacts in pink. Not surprisingly, cardiovascular disease, respiratory disease, infectious diseases, secondary to climate change. But these are either direct impacts here in blue, for example, heat waves that cause heat stroke and may lead to a patient appearing in an emergency department. Certainly we have storms, floods, and so on. But some of these impacts are mediated or indirect, and that can be, for example, a flood event that leads to poor water quality or quantity. So the poor water quality may result in an infectious disease that's waterborne or foodborne, and the quantity issue can also occur in places where there just isn't sufficient quantity of water for drinking purposes. So this cascade of a set of environmental impacts here in blue and green heading into these health impacts in pink is a nice sort of simplistic way to describe those impacts. For us in public health, it's quite clear that there are social mediators to health impact as well, whether this includes low socioeconomic status, certain communities that are disadvantaged perhaps, and certain occupations that may put us at risk or introduce a set of vulnerabilities. This is one particular framing, and I want to go through a couple of others for you because I find that some students may more easily grasp something a little bit more conceptual, as you see here, but others might in fact find something like this, which is a bit more patient-centric, to be a bit more easily digestible. I quite like this paper from Haynes and Ebi because it looks at the very beginning of this cascade of climate change impacts from anthropogenic carbon dioxide emissions, rising temperatures, and some of those environmental impacts like extreme weather events, all of which, again, are mediated by demographic, socioeconomic, and other factors, both positive or negative. For example, a negative impact might be from a pre-existing low nutritional status, for example, for a population. However, there might actually be early warning systems that might be in place, and that might actually be a protective factor. So this is quite nice because it considers both of those elements. But really what's quite nice here, and it might be more easily understandable to clinicians, for example, is exposure pathways. A continuation of this diagram on the next page shows that those anthropogenic impacts, climate events and weather events lead to these particular diseases at the bottom, so health outcomes, but these are categorized into exposure pathways. So, for example, we had heat stress earlier. That is one particular way that the body is exposed to the extreme weather event, leading to heat-related illness and death. On the other hand, we might have vector distribution in ecology, which changes, leading to a whole host of mosquito-borne diseases. So that can be a little bit easier for those of us or those of our students who come from a more of a clinical background, perhaps, or a health delivery background. Classic public health, though, of course, has to make an entrance here, and it's nice to be reminded of the social determinants of health. On the left, we have the Dahlgren and Whitehead model, which is quite well known. And what's nice here, of course, is that it looks beyond just the individual to the social and community networks and the living and working conditions, employment status, education, food availability, water and sanitation and hygiene, housing. And healthcare services are certainly one component, but only a small component relative to the general socioeconomic, cultural, and environmental conditions. This is not new for those of us who have worked or studied public health. However, I quite like this model by Barton and Grant, which kind of takes this to an even more upstream location. Again, starting with people at the center, very quickly thinking about lifestyle, community factors, and the local economy, where we have not just markets and employment, but also social capital, wealth creation, and taking that beyond the individual and the local all the way through to the built environment, considering the positive or negative impacts of the natural environment or the loss thereof, all the way out to the global ecosystem. I like this because it's quite holistic. It takes the environmental, essentially elements, water, air, and so forth, and biodiversity impacts, ecosystem services, and it also looks through these natural habitats, the built environment that we create for ourselves, and then climate change as well. So I hope that gives us a few different ways to frame the issue, not forgetting, of course, our First Nations colleagues who have quite sometimes a different, but actually very, very complementary and important approach to understanding the climate change impacts. Connectedness to country is critical to this. So this is one particular model from colleagues in Australia where ecosystem degradation has been placed at the center alongside extreme weather events, rising sea levels. So those climate impacts, which are actually compounded by colonial injustices, loss of identity, loss of culture, loss of country, which are quite integrated in their worldview, the individual in their environment. We then move out to the strain that places on social and emotional well-being. That does include body, so our typical kind of Western-centric or reductionist approaches to thinking about health, but also the mind, so mental health conditions, but also what that means for family, community, dislocation from country. Then this model goes out further to thinking about what some of those particular health impacts are, whether they're air pollution related or water quality related. So it actually also provides some solutions at the far extent of this figure, for example, self-determination, the importance of justice, relationality, as well as enhancing cultural strengths. So a few different ways to think about climate in terms of public health, typical public health framing, whether it's Dahlgren and Whitehead, the Barton and Grant model, or the First Nations framing. And I'd encourage you to look at these. I've provided hyperlinks and references to all of these figures as I go, but really thinking through which of these frameworks might complement your existing public health curriculum on your particular teaching program. Another important point of framing is to think about adaptation and mitigation and contextualizing that to the health service. I like this because this is quite a simple way to think about it, but we can introduce some public health elements to it. Simply, greenhouse gas concentrations lead to climate change. There are impacts to health. Our responses are essentially twofold. One is to adapt to what we can't prevent, and one is to mitigate whatever we can. A pithy phrase that's used sometimes is adaptation being managing the unavoidable and mitigation being avoiding the unmanageable. Some might argue, are we losing the battle to mitigate climate change because we do have ever increasing greenhouse gas concentrations, and we might have breached or are close to breaching the 1.5 degrees of global warming from the pre-industrial average. So should our efforts be on adaptation? I don't think we need to get into that debate for this purpose. It's certainly a good debate you could have in your classrooms. The conclusion might very well be we need to do both. And where the health service only does adaptation or only does mitigation, there will be limits to how much you can serve its population. We'll get to that shortly. One way to frame this same diagram is to say mitigation can be thought of as perhaps more of a preventative approach, perhaps primary prevention before the patient, so-called, has the disease. Adaptation can be considered somewhat curative or secondary prevention. The patient has the disease now, but it might still be a good opportunity to intervene relatively early. Let's move to part two now that we've framed some of the sort of high-level approaches to now delving into health system responses. So the World Health Organization has an operational framework, which I'll introduce here, for building climate resilient and low carbon health systems. That's one quite important framing that builds on the well-known 6 building blocks of health systems. Again, a WHO document. Another emerging complement to this is the low carbon or net zero health systems agenda. And in doing this, let's define some of these terms a little bit. So let's be really clear on what these dual goals for health systems are moving into the future in responding to climate change, both now and increasingly. So climate resilience looks at health systems that have the ability to anticipate, respond to, cope with, recover from, and adapt to climate-related shocks and stresses, so as to bring sustained improvements in population health despite an unstable climate. Whereas environmental sustainability is looking at healthcare facilities that improve, maintain, or restore health while minimizing negative impacts on the environment and leveraging opportunities to restore and improve it. Both of these definitions are from the World Health Organization 2020 guidance, and you'll probably notice that there are a lot of WHO documents that are coming fairly quickly and have been since about that time in 2020. So there are a few key ones that I've pointed out in this presentation. One way to think about this is associating climate resilience more with the climate adaptation work and associating environmental sustainability with the mitigation work. The World Health Organization 6 building blocks, for those who are not familiar, has been in place since at least the 2000s, if not earlier. It really looks at some of the elements or the building blocks required for an effective health service. These are health service delivery, so the delivery of care, a health workforce which can deliver that care, information, epidemiology, and data that underpins their work, medical products, vaccines, technologies, in other words, the supply chain, financing in order to pay for all of the above goods and services and salaries, and finally, leadership and governance that enables an effective service to proceed. These 6 building blocks have been retained, but then added to provide these 10 components in the 2023 WHO operational framework for building climate resilient health services and low carbon health services. If you look on the right-hand side, I've pulled out one particular figure from this guideline, which quite nicely demonstrates where health services should be heading. On the x-axis here, you have health systems that have low, medium, or high greenhouse gas emissions. And on the y-axis, you have the health system performance. So ideally, you would have a low carbon and high performance health service, which is this top left box. And quite a nice exercise is to ask your students, do you think your local health service or health system is high emissions, medium emissions, or low emissions? Typically, this is associated with the country's GDP, the country's relative expenditure on health services, and how do you think your performance rates? And you might categorize your health service in your country or your local health system as 1, 2, 3, 4, or 5. The idea being to bring, what are the strategies to bring that into a low carbon, high performance health service? Let's look at some of these 6 building blocks on the inner circle and the 10 components on the outer circle in a bit more detail. Some elements, I suppose, are non-negotiable. What we have here is a leadership and governance model, which is climate transformative, actually understands and appreciates and accepts its role, whether one is a senior executive, whether one is a manager, in leading some of the health services and their work. This is an active effort across services, but there are some great examples where this has worked. A lot of that is actually sometimes driven by a health workforce, which is so-called climate smart, as described here, a health workforce that is well educated on the health impacts, both in their individual clinical practice, in their public health advocacy, and also the public health responses. What should come naturally to us is some of these areas in green from a public health point of view, for example, health and climate research, assessments of climate and health risks, and perhaps less so now, but certainly in an emerging area, which is an appreciation of greenhouse gas emissions and their measurement. Again, an area that I'll cover shortly. An important development is the integrated risk monitoring and early warning systems that are developed. We certainly have these in public health for a number of issues, whether these are communicable diseases, environmental health issues like air pollution or heat wave responses. Now the question is, how do we integrate those effectively? In the blue here, you see service delivery, where we have this kind of critical area of climate-related emergency preparedness and management. And again, you can think back to those early few slides and relate this back to your own setting. When was a time that a climate-related emergency occurred? What were some of the public health instruments used? Was it a legislation? Was it a standing approach of collaboration with other agencies? In the example in Australia with our bushfires in summer 2019 and 20, we had strong relationships across the clinical services in health as well as the public health response. But moreover, we had strong relationships with our local state emergency services, police, ambulance, fire and rescue, and beyond that to our environmental regulator, which is also the EPA, Environment Protection Authority. So these groups came together and led a statewide emergency response, and these were localized as well. So these are quite critical day-to-day operational roles that public health practitioners have. The question is, how will they adapt their approaches or their standing approaches in the face of climate events? So that's where we come towards climate-informed health programs, which take more of a proactive view, not only responding, but then also working through the cycle of PPRR, prevention, preparedness, response, and recovery. That takes us towards management of the environmental determinants of health during non-emergency times as well. Financing, of course, is key, and sustainable funding for climate-related activities, whether they're routine programs or additional programs, is an important consideration here. I hope that helps frame the ways a health service or a health system can respond to climate events, or become climate resilient, as well as become low carbon. Some of these areas, of course, are not going to be achieved all at once. So a key issue here is to convey to students, what is your role going to be in this? Are you in a leadership position, perhaps? Right? Many of our students in masters and beyond are actually practitioners. Or if it's a more junior student, which of these areas might be a place where you will work into the future? Where do you see your career going? And it might be, for example, looking at climate-informed health programming. It might be a novel area for where you work. And so how do we build up that capability? I neglected this particular building block at the bottom here, which is climate resilient and low carbon infrastructure, technology and supply chain. We will focus on that now. So what I want to take us on next is the scope of health service activities and the supply chain. We know that while health systems are impacted by climate change, they're also creating an environmental impact and essentially exacerbating climate change through the greenhouse gases or carbon emissions made by delivering healthcare. It's an unfortunate reality. The question is, how do we tailor the scope of our activity and the level of emissions we're generating? Scope is a tricky word here, so I'll define it in two different ways. Considering the full scope of activities from a public health point of view might mean thinking through what are the health protection, health promotion, disease prevention, i.e. non-curative activities the health service delivers. But on the other hand, and probably more for climate and health responses, an organizational or business framing is more helpful, where we think through what are called scope 1, 2, and 3 greenhouse gas emissions. Essentially, this helps us to determine what are the carbon footprints or hotspots of high carbon but perhaps low effectiveness activities for health services. On the right, you have an example from the English National Health Service, NHS, and it's quite telling that much of the carbon footprint is a small part, in fact, is due to the delivery of care itself and the buildings and the outputs such as water and waste from those processes, and actually even less so from what individuals contribute, whether they're staff or patients commuting to delivering or receiving care. That in fact, it's about 2/3 of the carbon footprint is from the supply chain, whether it's medical or non-medical equipment, as well as gases and pharmaceutical products. So another nice teaching point for students is, if one was to make interventions to reduce the health impacts from the health system itself on climate change, where might the focus be? And the answer often is what's downstream, perhaps under the control of the individual clinician, the health practitioner, the patient, the staff. And often we forget this big, much larger contribution from the way the system's structured. So in classic public health fashion, we should be looking upstream and looking at the larger element of the impact. Let's define that in a little bit more detail because upstream and downstream mean something specific when calculating the carbon footprint. Upstream activities include things like purchasing energy, which is based often on fossil fuel extraction. But sometimes it might be based on renewable energy sources. So having a sense of that is quite important. Procurement of medical equipment and pharmaceuticals is dependent on manufacturing. We use a lot of water in our health services, which results in land use changes, environmental modifications, and so on. I won't read out the full list, but to give you a sense that these upstream activities have the health service at the middle of it, and then there's downstream activities from there, which might include the waste we generate, the water that we end up disposing, and the goods that we transport, whether they're people and products, and the air pollution that might result from tailpipe emissions of vehicles, for example. This is a visual representation of what I discussed, where scope 1 emissions are the direct on-site emissions, where in this case the company facilities refer to the health system or the hospital. Scope 2 refers to the indirect emissions, but predominantly the energy or the electricity that's purchased. And then scope 3 refers to all of those indirect upstream or downstream activities, upstream predominantly being the purchase and procurement of the supply chain and the transport to end up to provide that in the hospital setting, and then also downstream where a lot of those end-of-life product disposal, whether it's through waste streams or processing of those products, apply. At the top here, you see all the various greenhouse gases that are emitted, and this is a conceptual framework that helps us calculate the carbon footprint. So we've covered a couple of approaches so far, which look at this conceptual model of the building blocks, which is quite holistic and looks at all different elements of the health system. And then we've talked a little bit about how a business or a organizational framing can help use that information to calculate the carbon footprint, or in other words, the health impacts from the health service itself of climate change. Now, one thing I've been asked to cover here is integrating climate data into health system planning. And in fact, this is not something new. Most health services, at least certainly in some of the English-inspired health services or influenced health services, will have some legislation around public health regulation. So that legislation often ends up in things like this, which is health impact assessment. In Australia and many other places, a health impact assessment is a requirement when a major new development is proposed as part of a environmental impact statement. A health impact assessment is often done. There are a few different ways we can actually use this quite powerful tool when applied to climate change. Firstly, we can look at things like climate change and environmental health indicators. These are often so-called outcome pairs. So you have a health risk, which is an environmental risk, and then you have a health outcome. These can be paired across. A number of sites and a number of such indicators. This work was done by the Australian Institute of Health and Welfare, based on some work that we'd done at the New South Wales Environment Department, as well as the Health Department, or the Ministry of Health, and one of our universities. This sort of work is highly quantitative and sophisticated, but it's just an example of the fact that we have existing methods for calculating either an environmental risk from a particular environmental hazard, whether it be a chemical or air pollutant, or even indeed things like heat. But in addition to that, we have these ways to assess development proposals which change the land use pattern or the urban built form, which then has an impact to health in that indirect fashion. And in applying those, we can also include climate data. There's another whole set of climate data here, which is projections and meteorological modeling. And often there are existing processes that public health practitioners get involved with. For example, working with the Bureau of Meteorology in Australia when we have a heatwave warning, and then we have a number of government agencies that come together to provide public health messaging. From a teaching point of view, it's easy to get overwhelmed with a lot of these documents, but again, starting with what are the fundamental drivers for public health action. And so if you're a pure educator or working in an academic setting, it might be quite handy to reach out and to have guest lectures from those that are working at the interface of health and climate. Let's move on now in the kind of remaining 10 minutes or so to some of these rapid fire solutions and actions. What I'd like to get through is where can routine healthcare delivery actually provide some actions? So we'll look at things like sustainable quality improvement. If you don't have a robust approach to routine healthcare delivery that can consider climate easily, there is a document from the International Society of Quality in Healthcare, ISQA, which has produced a green paper on pathways for practical action. So I'll talk through that. But more broadly than that, there are a number of excellent research collaborations, whether small scale or large scale, a number of policy interventions now that are popping up at the national level as well as the local level, communities of practice that are so powerful in actually getting people that are educators, people that are practitioners together, and a lot of international activity that's kicked off, I must say, underpinned by advocacy by the very people in this room or the people that are listening to this talk, which is all of us as health professionals of one stripe or another, or educators of those. So let's go to the first point, action through health care, through routine healthcare. Now, there's this famous quote by Paul Batalden, the so-called grandfather of quality improvement in health, who said, everyone in healthcare has two jobs when they come to work. One is to do their job, and the next is to improve it. And this sentiment has been taken by Francis Mortimer and colleagues at the Centre for Sustainable Healthcare in the UK to come up with this sustainable value equation. It's a conceptual equation. We don't put numbers here, but it really forces us to think about not just outcomes for patients and populations, which are key to health services and their reason for existing, really, but it adds this denominator of the environmental and the social and the financial impacts, also known as the triple bottom line. So it does a few things at once. One is it's defining sustainability, not just as environmental sustainability, which is our focus here, but and also not just the financial bottom line, which is often the only way things are measured in health. That's not true, because it's not just the financial, it's not just the environmental or the social impacts that we're encouraging people to think about. It's actually underpinned with patient outcomes and population health outcomes. So another way to describe that a bit better is to say we can use quality improvement processes, for example, the Plan, Do, Study, Act PDSA cycle, and put an environmental sustainability bent to it. So this SUSQI method, or sustainable quality improvement, developed by that centre in the UK, takes this PDSA cycle and reorganizes some of those steps to think about setting goals, studying the system, designing the improvement, and then measuring the impact. I have found this to be a really, really effective teaching tool. We've run a number of workshops using this methodology. It's freely available online at susqi.org, and there's a whole set of supporting resources for this. So one really nice entry point for your teaching around what do health services or health practitioners or public health practitioners do on quality improvement, on environmental sustainability, is to bring those two areas together. This is also quite a helpful approach where you have perhaps more mature students or vocational trainees, not just those that are at the master's or bachelor's level. I quite like this framing from the Centre for Sustainable Healthcare because they talk about these 4 principles of sustainable clinical practice. For those who need it, take a closer look here. It's quite nice because it starts with a prevention framing, so it brings in public health principles. Then it talks about patient empowerment and lean pathways and low carbon treatment methods. So it's almost, you could draw a line here and say it starts with populations and patients, and then it moves to the hospital setting. And it's kind of this innovative next phase of actually changing our service models so that they're not just lean and efficient, but actually low carbon in how we procure our goods and services and the kinds of care that we choose to not deliver, because some care is low value and sometimes harmful. There's lots of literature also around some of these developments by the Centre for Sustainable Healthcare, so I'd encourage you to look at those as well. If you or your health service or your student cohort doesn't really have a clear place to start, the ISQA Green Paper is quite a good place. Essentially, it provides these 12 non-exhaustive but sort of indicative approaches, and some of these I've already spoken about. The way it's framed here is on the x-axis we have those, again, you'll see me using the terms upstream and downstream in a few different ways. This is not looking at the scope 1, 2, 3 of emissions, but actually is thinking about downstream, meaning activities that are closer to the clinical care delivery interface in the hospital setting, perhaps, and those that are upstream in terms of health system-wide actions. A lot of great examples here, which unfortunately I don't have the time to go through in detail, but we have things like legislation and government statutory inquiries that can put downstream pressure to have more focus on environmental sustainability activities. You might even have SUSQI interventions using that Plan, Do, Study, Act cycle. You might just have a bunch of people that get together through green teams and have this healthy competition of the green wards competition and so forth. So a lot more details provided in that document there. We have, swiftly moving along, we have research collaborations, for example, the Lancet Countdown, which is a large international Wellcome Trust funded initiative now. Australia has a particular link between its Medical Journal of Australia and the Lancet, and there have been multiple reports produced. This is a great way to get involved with some of the leading researchers internationally, and I'd encourage you to reach out to them, and it's an expanding network. Action through policy is critical, whether we think about things like the Ottawa Charter, which talks about reorienting health services and having healthy policies. In Australia, we're quite blessed now in 2023 that we have a national health and climate strategy. But this was based on over a decade of advocacy that we even needed such a thing. In its absence, a number of interventions had already occurred. For example, we had local climate change adaptation planning guidelines in our northern state of Queensland back in 2019. We had a statutory climate and health inquiry that was led by the Chief Health Officer of Western Australia around 2020. And then we have our National Commission for Quality and Safety in Healthcare, which has come out with an expectation that for a hospital to pass its accreditation and continue functioning, it should now address an environmental sustainability and climate resilience healthcare module. So these are amazing interventions and developments. And quite nice here as well is in another strand, the state of Victoria, which has developed from its health department some guidance for its local government colleagues, so tackling climate change and its impacts through municipal public health activities. This is a set of examples from Australia, clearly, but what I quite like is to express to students and actually ask them to go find. In fact, it might even be a nice assessment task to say, go find one particular climate and health policy, what has been its impact, what has been its reach, and what might be some ways to further implement this in practice. Another thing that's quite transformative and powerful is action through communities of practice. Here's an example from our National Health and Medical Research Council, which had a special initiative on environmental change and health back in 2019, 2021 through to 2021. Now, as that was developing, a lot of groups came together in that period, and you see here a lot of examples of a whole host of organizations, both government, academia, health professional organizations, as well as Indigenous organizations, which was quite important in our setting. They came together to develop this community of practice, which is more research focused. But here we have now a group that I represent as co-chair of the Climate and Public Health Education Network from CAFIA, which is essentially the group of academic public health institutes in Australia that teach Masters of Public Health programs. Again, this has been a group that's only formed last year, but it's brought together a whole lot of people that are interested either to learn more, similar to what you're doing on this course, on what are the impacts of climate change and health, and also then how do we teach this more effectively. So we have a number of teaching and learning forums. There's one coming up in a week or so, and we will be working further with those that are interested and bringing people along for that journey. To close, just a couple of sort of highlights of how far we've come as a discipline of climate and health, and those in health services wanting to make an impact. Here's some examples of action on the global stage or international stage. As mentioned, COP28 was essentially the first time that we had a dedicated day of thematic programming for health at the United Nations Climate Conference, and this was held in Dubai, and you can see a number of banners that were showing endorsements and for a declaration on climate and health by, at that stage, 129 countries, now more like 150 countries, and a lot of health ministers represented here. There's further description of some of that work that I was involved with here, and it really shows that centering health in the international climate and health agenda, or the climate change agenda rather, is a clear priority. But beyond that pillar of health in the international climate agenda is how do we have effective climate financing for health, and what are some of the solutions that health systems themselves develop, and some of the interventions that can be funded. That work is proceeding rapidly. Also quite inspiring to students is some of our international collaborations, and no doubt there will be many in your institution, your academic institution, or your health service as well. And this is some examples from the work that I did in Fiji on their Health National Adaptation Plan for Climate Change. And that cross-cultural or cross-system learning was quite valuable for me personally, but as you can see, it was quite an international group of colleagues who worked on this quite seminal document. Similarly, so that's an example from the Pacific. Here's an example from the Pan American Health Organization, focusing on some of the Caribbean countries where that region is retrofitting their healthcare facilities to make them safer, greener, and well maintained. So this is the Smart Hospitals project. There's quite a nice dashboard available online where, again, quite a sophisticated approach where you can filter across facilities right down to the community level across a number of different countries. These are quite nice approaches that are can be sustained as well into the future. Closing up with a couple of slides here to mention that advocacy is probably going to have to be the mainstay now of an increasingly geopolitically fraught world, where a lot of those lofty ambitions, for example, through the Paris Agreement to limit global warming, have been called into question. So sometimes you have to put your hand on your heart and sign an open letter. This on the right-hand side, you see a letter that was placed in one of our national newspapers in Australia by Doctors for the Environment. So there's some 100+ names on there of health practitioners of various types who came together to demand that the government have no further coal, oil and gas, fossil fuel exploration. We haven't gotten there yet, but these are important things to continue pushing towards. Not everyone's comfortable with the advocacy, but what's quite nice is the advocacy does drive some of the research activities. It helps drive some of the political ambitions as well, as we know. But quite nicely, it also helps bring into sharp focus that health professional associations themselves have a role to play. And so now, with the World Health Organization's Alliance for Transformative Action on Climate and Health, also known as ATTACH, Doctors for the Environment has found itself as a focal point for health professional associations worldwide, something we didn't really expect might happen, but a lot of the advocacy and the visibility has helped bring that particular organization to the world stage, and no doubt that'll lead to further work and galvanize similar groups. So we do have advocacy-related courses, of course, on our Masters of Public Health programs around the world. So I encourage you to also think about perhaps liaising with some of those civil society or non-government organizations, perhaps also considering classic public health advocacy for specific health conditions, for example, tobacco or sugar-sweetened beverages, and what that might look like in the climate change era. My final slide is this. In public health, our role is to think upstream, and I quite like this comic that was produced during the COVID-19 pandemic, where we had our health promotion messaging down here in the city on a hill, where we had this big wave of the coronavirus approaching. Very soon it was clear that we had these economic impacts as well. So you can start thinking about the financial bottom line, the social bottom line, but really looming large was this environmental bottom line of climate change. So perhaps not the happiest of reminders to end on, but really it's a way to think through a health service, which might be this small isolated location on a hill, integrated across diseases that we prevent and treat, but certainly integrated throughout a social, societal and economic environment, which ultimately depends on a built and natural environment. So bringing those things together, I think, is our challenge, and a happy challenge for those that are teaching on this topic. Just as a reminder, we focused today on the topic session 9, which is on strengthening health systems and ensuring health service delivery. So I've talked about that in terms of health system responses to climate change. And as you can see, there's a lot more here to unpack. Thanks very much, folks. We'll leave it there for now, and very happy to take questions offline after the course is complete. Thank you very much.
Aurelio, Would like to thank you, Dr. Adi, for this very comprehensive presentation. And I think most of you, during all the sessions that we had, you heard a lot about the WTO building resilient and low carbon health systems. And also you saw this kind of mandala with this 10 blocks that we need to oversee to build resilience. And what is resilience? Resilience is the capacity of population, society, and the health system to prevent, to respond, and also to be able to recover after a climate change impact. And I received many questions for Dr. Adi, and I will pass the questions to him, and I will share with you some of them I already answered in the chat. And one person is asking about the health determinants of health, the determinants of health, the list of determinants of health, and I think it's linked very well with our next presentation, and I would like to present Dr. Raj Ghosh. He is a physician with more than 30 years of experience in infectious disease control, health system strengthening, and primary health care in India and South Asia. He is currently a senior advisor at the Public Health Foundation of India, where he oversees the foundation's work on One Health and environmental health. And before, Dr. Ghosh served as a deputy director for infectious disease and vaccine delivery at the Bill and Melinda Gates Foundations in the office. And he was also the director of the infectious disease at PAF South Asia and a regional director for the WHO National Polio Surveillance Project in India. It's a pleasure to have you here, Dr. Raj. Please, the floor is yours.
Thank you. Thank you. So I'll share my slides, and in case I have a difficulty, then I'll reach out to you. Can you see the slides and can you hear me?
Yeah, so you have to put in presentation mode and
yeah, I will do that. Yes, I'll do that. Give me a second. Okay.
Perfect.
Can you
Thank you.
hear me and can you see the
Yes.
slides? Wonderful. Okay. First of all, greetings to everyone, and thank you for this opportunity to connect with all of you, albeit virtually. The presentation that I'm going to make is on the health system's response to climate change, and we will look at a case study from Kerala state of India, where there was a devastating flood in 2018. But before I make the presentation, I just have two submissions to make to you. I have only a few slides to present to you because I really want this session to be a little interactive. I want to hear from you, your thoughts, your questions, and learn from each other. One of my professors in public health used to tell that public health presentations should be based on 3 A's. The first is the audience. The second is that it needs to be action oriented because public health is all about action. And the third is that it is based on anecdotes because anecdotes really bring the scenarios to life. So I have tried to keep the audience in mind, public health professionals. I've tried to talk about some of the actions that were taken, and we will look at some of the anecdotes related to the flood and how it was managed. The same public health professor in another class had told us a very important lesson that public health is about 3 P's. The first P is about people. Public health is all about the people. The second P is about priority. There are too many health problems across the world, and therefore we have to prioritize our resources as to how we deal with them. But there's a third P, which is very, very important. And this is about the politics, how politics drives public health action. So in the presentation, I have also tried to tell you about the people who were affected, about some of the priority actions that were taken, and finally, some of the politics that drove or undrove the actions that we saw as a response to the flood. There are three topics that we will discuss. One is we will look at India through a climate change lens. We will hear about the 2018 floods in Kerala and how the state, and here the state includes the central government, responded. What are some of the lessons that we have learned from the floods and its management? India is a land of 1.46 billion people, the fourth largest economy in the world. 48% of the population lives in urban area, and we have a diverse terrain. We call India unity in diversity. There are the Himalayan mountains in the north, the third desert in the west, the Gangetic plains across the heartland of India, the Deccan Plateau in the south, and it has a coastline of 7,000 kilometers. 27 out of the 36 states and union territories of India are prone to disaster. 58.6% of India's land is earthquake prone. 12% is prone to flood and river erosion. 5,700 kilometers out of the entire 7,500 kilometers of coastline is vulnerable to cyclones and tsunamis. 68% of cultivable land in India is drought prone. 15% of the land is landslide prone, and urban flooding has been reported from 5,161 local urban bodies. Before we move further, I wanted to talk a little bit about the outcomes of climate change as we see it on human life. There are four peripheral outcomes that we see. One is the various disasters that happen, the floods, the cloudbursts, the earthquakes, the various kinds of natural disasters that we see. The second is about the various diseases that happen because of climate change, including the acute respiratory infections, including various infectious diseases, which shift in the epidemics of dengue, malaria, various vector-borne diseases, the disruption of the various livelihoods that happen because of climate change of the humans, the change in the agricultural practices, the change in the traditional professions that people used to have, and that is the result which causes displacement of population, migration of population from their long-standing places to a newer destination, to newer health systems, to newer kinds of terrain. So therefore, the disaster, disease, disruption, and displacement, the 4Ds, happen peripherally. At the center of it are two things. One is that the impact is not uniform everywhere. There is a diversity based on geography, based on the various kinds of other factors, socioeconomic factors that happen. And therefore, there is a whole disproportionate impact that happens on different segments of the population, different communities. And these two have to be kept in mind as we discuss any outcomes of climate change and disasters on human life. An overview of climate-induced health risks, exposure, and vulnerable pathways for women and children. This is a compilation that CEEW in India had done based on UNICEF's 2024 report, A Threat to Progress, the Impact of Climate Change on Children in Sub-Saharan Africa. It talks about four things. One is about the vulnerabilities, factors that determine women and children's ability to cope and adapt, the geographic location, the socioeconomic status, the healthcare and education access, and the pre-existing illness. The various factors that lead to multiplied effects, which means that the escalated effects, water scarcity and contamination, food insecurity and contamination, infrastructural damage that happens, the service disruptions, and the displacement of population. There are various hazards that happen and that impact the vulnerable women and children severely. And these are extreme heat, droughts, floods, cyclones, and extreme precipitation, due to which we do see cloudbursts and other things happen. And this has become quite common in countries like India now. The impact that happens is because of all of this is that there is malnutrition in children, there is increased vulnerability to infectious and non-communicable diseases, there are neurodevelopmental and mental health issues, there are stillbirths and congenital defects, and finally, the infant mortality also increases. Now we go to the case study on the health system resilience from Kerala, the report that we have. I have included a couple of links for all of you to visit later to study in more in-depth various research and various studies that have been conducted based on the Kerala floods, which has been called the disaster of the century. But before that, we would like to introduce Kerala to you. Kerala's coastline is about 580 kilometers and is bordered by the Arabian Sea to the west. The sex ratio in Kerala remains highly favorable to females. There are 1,084 females per 1,000 males. It is significantly above the Indian average of about 940 females per 1,000 males. Kerala has 94% literacy, 96% of males and 92% of females are literate. Kerala continues to record India's highest literacy rate, about 94%, as we talked about. The urban population in Kerala is about 47.7%. And very recently, Kerala has been the first state in India to have eliminated extreme poverty from the state, a magnificent feat. So what happened in 2018? In August of 2018, Kerala faced catastrophic flooding, which resulted in a loss of 483 lives, and these were reported, and caused extensive damage to infrastructure, agriculture, and environment. And I will say upfront here that the data we need to be skeptical about, because there have been multiple data sources showing multiple number of lives that were impacted in terms of death, in terms of the sickness, in terms of being impacted otherwise. And these numbers data has always been a point of contradiction, which we will also see later between the different agencies. Severe flooding happened in 13 out of 14 districts in the state. As per the Indian Meteorological Department's data, Kerala received 2,346.6 millimeter of rainfall from 1st of June to 19th of August, in contrast to what it had received in the past years of 1,649.5 millimeter. The rainfall was about 42% above the normal. The rainfall over Kerala during the months of June, July, and the 1st to 19th of August was 15, 18, and 164% respectively above normal. What I want to highlight here is that while there was a rise in June and July and the state was gearing up, they never expected that in August it would rise to 164% above normal. Due to the heavy rainfall, the first onset of flooding occurred towards the end of July, and the severe spell of rainfall, which was experienced on the 8th and 9th of August, completely shattered all the preparations that had been made. Here is a table for you to look at later about the various districts in Kerala, and what were the rainfall in terms of the normal rainfall, largely excess, and excess rainfall. As you see, there were two where there was a large excess of rainfall, 2 districts, and in Kerala, it was an excess of rainfall. Normal rainfall expected was around 1,770, and 36.2% above that was reported, 2,411, and this completely threw the state's entire preparation out of gear. What were some of the immediate outcomes? 5.4 million people were impacted. and 1.4 million people were displaced because of this heavy rain. 341 landslides across 10 districts caused major havoc, forced water release from 37 dams in the state because there was no other way. Otherwise, everything would have collapsed. Reported lives lost were 433. This is the reported. As I again want to emphasize, there are various other reports showing many more lives having been lost and impacted. The economic loss, World Bank estimated total economic loss was about USD 3.4 billion, again contested at various levels, and there are multiple figures that you will see in the various reports that you read about Kerala flood. Some of the responses that happened immediately, and there are two kinds of response. One, that established agencies who had the mandate to respond, they responded. And then there was a response from the unorganized communities which were not prepared to respond, but took up their mandate. So we will see all of that. The established agencies, what happened was that the coordination of all the agencies, include the state, central, and the local government bodies, they coordinated. Development partners joined, community-based agencies were called, and the various communities in themselves participated in this coordination effort. The National Crisis Management Committee met daily, chaired by the Cabinet Secretary, who is the highest level of the bureaucrat in the country, in Delhi, to monitor the interagency coordination. Similar kinds of committees met at the state level, and they coordinated with the central government in terms of the response that had to be made. In terms of the various departments, the Indian Army launched what it called as Operation Sahyog, which means the support, operation support. The Southern Naval Command gave the operation a name called the Operation Madad, which is the Operation Help. Helicopters, aircrafts, 182 rescue teams, National Disaster Response Force, Central Armed Police Forces were put in place. There are a large number of figures. I have not gone into the numbers, but the response was massive from both the central and the state government. Central government provided medicines, disinfectants, and sanitary napkins. And the National Institute of Mental Health in Bangalore deployed psychosocial teams for rapid assessment and community-based psychosocial counseling. The role of the communities was marvelous, decentralized. It was non-institutionalized community effort, and it demonstrated exceptional local resilience in face of this calamity. Particularly who were called out were the local fishermen community, who emerged as the exemplary first responders before any response came from any of the agencies, deploying over boats and fishermen into the torrential rains. The severity of the 2000 floods led to an intense scrutiny of the state government's preparedness and dam management practices. And this is a highlight of the various lacks and lacunae that were later on identified in terms of the immediate response that the state and the central government provided in response to the floods. And what was found out was that the preparedness was completely lacking, and the state obviously wasn't expecting the kind of floods that would happen. Neither were there warning signals from the various departments, including the Indian Meteorological Department, about the torrential rains that were to come. And this revealed a significant systemic shortcoming. These three priority shortcomings that were identified. One was about lack of flood moderation, which means that none of the dams were operated for the purpose of flood control or moderation. No effective flood control zone was maintained before the floods happened. There was a sudden water release that happened, which actually caused an escalation in the rise of the water and therefore the calamity of the flood. high reservoir storage levels were maintained even in the first week of August, when there was already indication that June and July there was unprecedented rise in the rainfall. The subsequent necessity for sudden, uncontrolled release of water from all dams simultaneously severely compounded the flood impact downstream. There was a critical absence of scientifically identified rule curves, which are operation manuals, which define the entire, how the reservoirs and others need to be maintained during the different times of the year. And the mandatory emergency action plans were not there. The judicial recommendation called for a more detailed inquiry by an independent expert committee headed by a former Superior Court judge, and which emphasized the necessity for future measures such as floodplain zoning, inundation maps, and updating the rule curves, which means how the dam and the water reservoirs need to be managed. There were conflicts, contradictions, and controversies. And this is where, I talked about the politics earlier. It became at the forefront. The fund released for rehabilitation, there was a dispute between the center and the state on the fund allocation, its management, and submission of the utilization certificates for reimbursement. There was a whole discussion about how the fund needs to be dispersed. And there was a whole controversy around the non-submission of the utilization certificate by the state, and therefore the non-reimbursement of the cost by the central government. And this took a major turn because the center and the state entered into a major conflict in terms of the fund release and the fund management. The second was that, post-tsunami, India had made an informal policy, nothing set in stone, about not taking foreign aid and focusing on self-support, the Atmanirbhar Bharat, which the self-sufficient India for disaster recovery. And therefore, foreign funding, particularly from the USA, was refused for this management of the floods and the recovery and the resilience. There was a failure of the early warning systems. Obviously, there was a blame game that started between the different departments as to who was responsible for the warning and, who failed and who kind of did not take action. There was a delayed response to the calamity, and therefore the state government blamed the center blamed the state government, the local governments blamed both the governments about, inaction, and therefore there was a lot of dispute around how the response came and who was the front line in terms of the response. And finally, on the impact of the devastation, the lives impacted and the economic loss, there were multiple figures and multiple kind of versions of how many people were impacted and what was the economic loss. But what I presented to you earlier was what the World Bank had estimated. But something very good happened in terms of the recovery and the resilience of the health system phase. One was around the path to Navakeralam. Nava means new, and Keralam means the state of Kerala. Following the immediate response phase, the government of Kerala demonstrated a commitment to long-term resilient recovery. The state government led a comprehensive post-disaster needs assessment, employing the global methodology developed by the UN, the World Bank, and the European Union. The post-disaster need assessment involved 76 experts from 10 UN agencies and the European Union, along with local experts and also hyper-local experts with local stakeholders across 120 villages, in which the self-government, which is the panchayat rule, the panchayat system at the very grassroots level, was pulled into the development of the plan. The rigorous assessment estimated that the total recovery needed was a substantial USD 4.4 billion. Crucially, the assessment went beyond merely calculating the damage, incorporating the community stakeholders to develop strategies tailored to vulnerable groups, including substantive recommendations which were focused on environmental sustainability and gender inclusiveness. We can summarize to say that the first slide that we had seen in the core, the diversity and the disproportionate impact was taken into account. It was very well understood that there are vulnerable populations which will be impacted disproportionately, and therefore there needs to be a special planning for the socioeconomically weaker section, for the women, for the extremes of age, for the various kinds of people living in remote areas. And therefore, this was the plan that led to the new Kerala planning.
Dr. Haj,
There was another,
I
yes,
really would like to ask you to conclude your presentation in
yes,
1 or 2 minutes
just,
because we still have another presenter. Thank you so
absolutely.
much. Sorry.
In terms of the Rebuild Kerala initiative, there were 6 initiatives. The first was around the eco-sensitive planning that was done, making Kerala the first green state in India. Risk-informed construction that was done. A local development using local materials was put into action. And this Rebuild Kerala initiative supervised substantial rehabilitation efforts, and in-housing reconstruction was done and monitored by the Rebuild Kerala portal, which was put on web. I have kept a few websites and resource materials for you to read and go through, and thank you.
Thank you so much. This is a very comprehensive and very didactic presentation, and I think all of the participants here, they are faculties and students, and they can see the importance to connect with the communities and how communities they can be better prepared to also address and help during this time. And I have some questions for you, but to the end. But I will call our last speaker. Thank you so much, Dr. Haj. Now we have the presentation of Dr. Phil Dowling. He is the Global Director of Sustainability for Johnson & Johnson. Phil leads the Johnson & Johnson Environmental Health Strategy Development and develops partnerships that aim to improve environmental quality and human outcomes in support of J&J broader mission of improving global health. So Phil, thank you so much. Over to you.
Thank you so much, Danielle. Can you see my screen now?
Yes, perfect. Thank you.
Oh, excellent. So, yeah, hi everyone. Phil Dolan coming to you from New Jersey in the US today. One of the things that Danielle didn't mention, but is that I've spent probably the last 25 plus years of my career embedded in healthcare supply chains. So I'm going to speak to you about one of the ways that climate change is indirectly impacting health, and that's through impacts to the supply chains. So what do we mean by, I'm going to give you a little bit of background by what we mean by supply chain continuity, and then like, where are the main areas that climate change is impacting on those supply chains. And then we'll cover a couple of quick case studies since we're a little bit short on time. But supply chain continuity is really the ability to keep supply chains moving and ensure that there's a durable, reliable, and persistent flow of goods and supplies to the customer. And in the case of healthcare, that's to the point of care. So there's a couple of key elements of supply chain continuity that we look at. First is understanding the risks that the supply chain faces. And these days, to be honest, severe weather events are basically, top of mind for supply chain risk management professionals. So we look at the risks, and then we develop plans to address them, continuity plans, backup processes, alternative plans. But, as everybody knows, the best laid plans don't always work. So you need to be flexible and agile to handle these challenges, especially, things like large weather events like typhoons and hurricanes that can really significantly disrupt the supply chain. Probably the area I've seen the greatest advances in supply chain risk management continuity in my career is in the use of technology to really provide real-time visibility to what's happening in the supply chain and be able to reroute and deal with these disruptions. But even with all that technology, there's still a lot of collaboration that's required between suppliers, between logistics, between suppliers and customers to really mitigate these risks and keep moving forward. Now, I said I've been, embedded in healthcare supply chains for the last 25 years. So I use the term supply chain continuity. And that's really kind of a historical term. Supply chain resilience is really becoming the term of the day. Everything in healthcare is focused on resilience. So we see, people talking about supply chain resilience, and one of the criticisms of supply chain continuity as a term or concept is that it's more of a reactive approach. But what I've seen over, my career is that there's been a lot more proactive elements involved. So really at this point, we can kind of use supply chain continuity and supply chain resilience interchangeably. So where are the main places that climate change is impacting on supply chains? One of them is transportation. So severe weather. This is a picture from Oklahoma after a tornado. So, it's hard to plan for things like tornadoes. Typically, supply chain interruptions due to transportation tend to be short term, so they don't typically produce long-term impacts to the supply chain and result in significant shortages in healthcare unless there's really significant damage to transportation infrastructure, which can happen. I would say more commonly we see, damage to manufacturing locations and warehouses. And again, it could be, tornadoes, flooding, drought, smoke impacts from wildfires, and all of these severe weather events also impact the ability of employees to get to work, right? So you might be running reduced shifts and things like that if employees can't get to the locations to work on producing healthcare supplies. Another area where we're seeing impacts of climate change on the supply chain is in terms of raw material availability, especially things that are agricultural based. So if you get severe droughts that are long term, that can really impact the supply of raw materials. Again, especially those ag-based materials. So first case study I'll touch on here is this happened in 2023. In North Carolina, there's a significant pharmaceutical plant, and they have a warehouse on the site. And there were a number of tornadoes in the area, and a very strong tornado, an EF3, if you're familiar with the tornado rating scales. It ripped through this plant, and especially right through the warehouse where a lot of the finished goods were being stored before being sent out for distribution. So that plant produced, roughly 150 different drugs. And the key part is approximately 8% of all the sterile injectable medicines used in hospitals in the US were coming out of that plant. So they had to implement, emergency ordering procedures, especially there were, 12 drugs with high medical need. They had to put in, emergency management plans to really manage the stock and ensure that, hospitals are not stocking out. And it took basically to the end of the year for the plant to recover. And, some drugs were off the market until roughly a year later. So that was a significant event. And that was just from a small event being a tornado that hit the plant. But we've seen larger events, especially, in the last decade. The first one we saw was Hurricane Maria, and it hit Puerto Rico as a Category 4 hurricane, and it damaged, many of the medical technology and pharmaceutical plants that are on the island. And you see that map there to the right, and you see how concentrated the medical and pharmaceutical supply chains are in Puerto Rico. So it's a very vulnerable location from that perspective. One, from the fact that they do get hurricanes, and two, that there is such a concentration of the medical industry there. So one of the plants that was impacted was a plant that supplied a significant portion of IV fluids to the U.S. market, to hospitals in the U.S., which really resulted in a lot of elective surgeries being postponed or canceled and rationing of IV fluids for other uses. And it took the plant roughly 6 months to get back to normal production and start to address the backlog. One of the things in Puerto Rico, too, from a supply chain fragility standpoint, is the grid is not very robust there, right? So all of these plants on the island were basically operating on emergency backup power for up to a year. So that really put stress on the supply chains for, diesel and things like that to the island to be able to continue production. And you'd think we learned some lesson, and to an extent we did. So people started moving plants, and North Carolina was viewed, even though I touched on the tornado earlier, but as a kind of climate safe area, especially up towards the mountains. But when we had Hurricane Helene last year hit North Carolina, there was major flooding throughout the area. And unfortunately, the owner of the plant in Puerto Rico with the IV fluids was also the owner of the plant in North Carolina that was hit by the flooding. All the access roads to the plant were wiped out, and as you can see in the picture here. And again, this plant was now producing 60% roughly of the IV fluids for the U.S. market. And again, we saw situations where we're canceling or surgeries, we're rationing IV fluids, and it caused some changes that actually exist to today where hospitals have reevaluated how they get fluids into patients and hydrate them. Do you need an IV? Can you give them oral hydration? Things like that. So this had a significant effect on the U.S. healthcare system. But it's not just the U.S., as Dr. Ghosh noted. Just in my own personal experiences, I've been aware of and involved in, responding to floods in Germany. Here you see a plant that was manufacturing personal care products that was flooded out during the floods in Germany a couple of years ago. Of course, a lot of people are probably aware of the, 0 day that was approaching in Cape Town, South Africa, that shut down most of the manufacturing there, including some plants that were producing OTC medicines. I've seen extended droughts in Sao Paulo state in Brazil, that resulted in water rationing and slowdowns of plants. They didn't actually shut down all the way, but when water is not available, it's very hard to make medical products. Same thing in India. While Dr. Ghosh was dealing with flooding in Maharashtra state, we saw, severe drought forcing water to be trucked in, and you need high quality water for manufacturing medical products, and if it's contaminated, it can cause impacts to manufacturing and cause shutdowns, especially if you end up with contamination of a plant due to water that's not the right quality. So what can we do? Obviously, we all need to work together, suppliers, transporters, logistics, and procurers too, to ensure that we can ensure the continuous supply of key materials to healthcare, because it's very hard to deliver healthcare without the medical technologies and supplies and pharmaceuticals that we need to treat patients. So, it's critical that as suppliers, we, take supply chain risk management quite seriously, and that it's integrated into the culture, right? That we build business continuity plans as we go, ensure that our supply chains are flexible and agile, and that we can respond to these events. Same thing with transporters. You have to be flexible, nimble. One of the things that I've seen too in my career is, as we try to address climate issues and avoid air travel, and put as much stuff, as on ground shipment as possible. Ground shipment is increasingly being impacted by severe weather, which then forces you to go to air travel, which then increases emissions. So it's a kind of a vicious circle there. So we need to be nimble to ensure that we get, products to patients. And then as procurers, carefully managing safety stocks, critical supplies, and ensuring there's redundant procurement strategies. So again, that we can respond to these. So let me stop there. Hopefully I stayed on time. I know that was very fast, but let me stop sharing.
Thank you. Thank you so much. That was
Cool.
very, very interesting. I think it's a totally different perspective that we can have here, and also it's good for us to have this idea that how it's a cascade impact in many different ways, and let me and how we can also overcome all this major impacts on health, and also build this resilience together with the private sector, and bring all these stakeholders together. I would like also to ask Dr. Haj to open your camera. We don't have much time, so I will make a question for both of you. My question is very simple. After all this disaster, what was the lessons learned, and what have been done to be better prepared to another event like this? So Phil, since
I
you're
think
already
so.
here.
Yeah, I think it's just the awareness that climate change, severe weather can cause significant impacts, to the supply chain, to the ability to get products to customers and patients, and incorporate that as a normal part of our supply chain, risk management processes. It just has to be part of it. And we've seen that, to the part where, as much as we worry about geopolitical risks and, other things like that, climate change is just now it's just a normal risk that we consider as part of all of the supply chain risk management planning and contingency planning.
Thank you. Thank you so much. Dr. Haj, any thoughts on how
Yeah.
Kerala now
First
is
of all,
working after this?
yeah, sure. But before that, I really wanted to appreciate what I heard from Philip. Fantastic perspectives. Thank you so much for this wonderful insights. Uh, Two things. One is, I think, we will have to understand that the community will always continue to play a very important role in terms of the risk aversion and also in terms of the response that they do. The first response will come from the community. So, therefore, I think capacity building of the community in terms of their own uh, mitigation efforts and also in terms of how they respond to it is very, very important. And the second, I think, I'll reflect on what Philip said. I think we really need to have resilient supply chains because it is so important for us to ensure that life-saving public health goods, including the drugs and all the other kinds of requirements that are there, need to be there at the spot when such disaster strikes. So I think resilient supply chain is a very, very important component of the whole planning process and the capacity building of the community to be the first responder.
Thank you so much. So we don't have much time, so I really would like to thank you, all of you, to being here. And I think we conclude with the conclusion of Adi. We need collaboration, collaboration, and collaboration. This is a very complex topic, and yeah, and we need to collaborate, and we need to involve everybody, and community are the key and the first responders, and they need to be aware also to self-protect themselves. So thank you so much. We have almost more than 1,000 people here today, so that really shows the importance of this topic. Thank you. Bye.
Thank you. Bye bye.
Bye-bye.